Hi, welcome to another episode of Talk Nurse with me. Today I am joined by Nama. We're going to introduce her in a bit, but first we're going to talk about our wine highlight, what we're going to be sipping on this episode. So I told y'all before, I've kind of been on like my little healthy wine kick. So this is supposed to be a healthy alternative, so that's why I got it.
Oh.
It's like less calories, less sugar and stuff like that. So what we're drinking today is Tiny Umbrellas. It's pink Moscato. So the flavors is raspberry, peach, and passion fruit.
That sounds good.
Yeah, and I've come to find out, me and passion fruit, like...
Best friends.
Yeah, that's my flavor. It's 8% alcohol, and I didn't find what it's to be paired with, but they said it kind of goes with everything.
I would think so.
And they gave us like a little cocktail at the back. That's why I was asking you if you had lemonade, because it was saying like lemonade and club soda with this, like makes it good. Yeah. I was like, I want to kind of try it, but I was like, I want to kind of taste it by itself too, just to see how it does. So... that's what we're going to be drinking today, you guys. So we're going to let you guys know how we like it. While I'm pouring this, I'm going to let Nama introduce herself to you.
Hi, I'm Nama. I work, or used to work with Lainey.
I
She broke it off recently. For like, what, 2 years?
1 year.
Oh, wow.
It feels like a long time because a lot happened, but no, we were only together 1 year.
Yeah, we worked together for a year, and I've been a nurse for almost 3 years. I'm in grad school. I don't know why. I'm trying to get my NP, but yeah.
She's not trying, she's doing it, y'all.
Doing it.
Full-time working and going to school.
Losing my mind. Yeah.
It's not for the faint of heart.
That's good.
Oh,
I don't taste the alcohol at all.
We found another wine we like.
I don't think we're gonna have enough left to make a cocktail after this.
No, that's fine. We can drink it all. It's not even that. It's like only 8% alcohol too. That's so funny. So this bottle's about to be going. Y'all keep a record of where we're starting from. And these cups are pretty big.
Yeah.
I always have to pour it, and I'm like, damn, there's still some left in there. Yeah. These Mark cups are good. Yeah, so we're gonna have to buy this again at our next little event.
That and the other one before that.
It's too many.
Too many to keep up with.
Oh yeah, if you guys watch my vlogs and stuff, y'all would have seen Nama before in our Galentine vlog, and she probably made an appearance in one of my Come to Work With Me vlogs. I know Sydney has.
Yeah.
So now we're gonna talk and actually we're gonna play a game. Would you rather? Okay, would you rather have your first 3 hours of work be busy or your last 3 hours?
First 3. I have no energy during the last 3. Like, I've had my coffee in the morning and it's already busy to begin with. So just throw it at me, because at the end of the day, I want to just be able to wrap up and sit there. I don't want to come at shift change.
I just hate like being thrown into my shift and it's like orders, blood, blah, 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 that. And I'm like, dang, like 9 o'clock already be too much. Because it's like, everybody has all their meds in the morning. It's kind of like scattered throughout the day. So it's kind of like, all right. But then at the same time, like you said, it's just like once the last 3 hit, it's like, all right, I'm trying to go home. I'm not trying to do nothing.
Especially if you've already had like lunch and you already thought you were done for the day.
That's true.
That's the worst when you just like.
But at the same time, it's kind of like, well, then I don't have to do anything else, and it makes the time go by faster. Because sometimes I just be like, I want to hurry up and go home, and then sometimes I just be trying to chill. I don't know what I would pick. I guess
double-edged sword. It's like.
I know, because it's like the like you said, the first 3 hours of work already is busy. So
but it depends on what kind of busy, like new admission busy or like Dr. Quick busy. You know,
it's too many variables.
I need more details.
We need answers. Y'all comment down below and let us know what y'all think. Okay, would you rather document during the code or administer medication?
Meds.
I already knew her answer. That's why I put it in there.
Like, I don't care if my name is listed under documentation for that day. I will grab the pen, or I will get on the chest, and someone else is going to have to figure out how to code. I mean, document.
No, Nama's always doing meds whenever we do rapid response, guys. Like, all the time. And the intubation thing. Remember that time?
Yeah, so we're struggling to figure out
I can't do simple math. I'm like, I think this times this is that, right?
And then eventually, we just pulled out your phone and we were like, let's check.
I was like, my brain's not working. There's too much going on right now. Let's just... I used to document all the time at my other job. Like, every time I was the documenter, like, I'd just come in and I'd write on the board. What time we start chest compressions. And I think, too, because documenting is kind of, I don't want to say it's like team lead, but, like, you're kind of assisting the team lead.
You're telling, basically, everyone like, to do. I mean, even the ICU doctor will look over at you and be like,
how many more minutes?
What have we given? Like, I don't mind in the middle of the code to be writing everything down. I feel like I'm good at that. But then I don't want to, after the code, get into Epic and start charting.
Oh, that's true, too.
That's what I don't want to do. Like, I don't mind, like, writing it all down.
I don't remember what I used to do. I feel like when I documented, well, at my old hospital, it was paper. And then I guess, no, we didn't chart it. That's why. That was the difference.
We used to do paper, too, remember?
It was just paper. It wasn't the one. So are they doing it now where you do it on the paper and then chart it in Epic, too?
I think they mostly want it on Epic at the end of the day. And it's weird because you're supposed to be doing it in like real time, but we're obviously not. So then having to backtrack down to the minute is
okay, that would be different because, yeah, in my first job, it was just all paper. So it was like no problem. We didn't go back in the system and like put it in. We just do it on the paper and put it in the chart.
Yeah, you just check mark like,
okay, so that's different then. I don't think I would want it because I always told them this when I first started that job. I was like, so if there's a rapid or a code, I'm going to have to go find a computer because we don't have computers in our room. That was my problem.
And then you know how long it takes to like log on?
And to go find a cow. First, let's start there. You gotta go find one. See if it works. Is it the kind that needs to be plugged in?
Does it need to be rebooted?
Is the mouse working?
Is the scanner working?
That's what I'm saying. That's why I'm like, no.
And then it expects you to also put in the names of like who's who. Remember at the beginning? Supposed to put in the
like
doctor,
who's doing what. Yeah.
I do not have time for that.
We did that too with the paper, but it was more so like at the end, like, hey, what was your name again? Well, hey, what's your name? What's your name?
Yeah.
But okay, I don't think I would want to do it with the electronic system then, now that I think about it. So I'm going with administer meds, even though it's very nerve-wracking. One time when Vivian was doing freaking chest compressions, you remember on that patient, my patient we were just talking about actually.
Yeah.
His whole body is like rocking like this because Vivian's so strong, y'all. She's like bodying him, like she's like going. Yeah, and his arm is just like, and I'm trying to grab his IV.
It's really just like
flailing leg, and I'm just like trying to get them to connect. And I just had to like hold his arm down and like do it like this so I could make sure the door lock was in yet. And I was just like, oh my god, this is embarrassing.
No, but the worst part is, I don't understand why it's so complicated. Like, I don't get why they can't just have simple little vials. Like, I don't get why it's a whole.
Why don't they already have preset syringes with the amount?
Yeah, I don't get the whole like thing that. So that part in the beginning.
Oh yeah, because you have to construct it together.
And
first,
then,
okay, Kim, let's go into business. No one's still our idea. We need to make that up. What the hell? Why isn't it? It should already be assembled. You should just pull it from the crash cart because the crash cart, once you use it, you have to change it out in pharmacy.
Yeah.
So it already be preset syringes.
And
already assembled.
I don't get why they're not, already together, ready to push.
That's what I'm saying, because that's a waste of time, too.
Because I know it has, like, a little secret little needle or whatever.
Yeah, it does.
I don't understand what the point of that is.
Me either. Yeah, but they definitely should already have preset syringes already assembled, so you could just pull it out the crash cart and be like, here.
All right, we're meeting again after this. We've got things to talk about.
What is like half a milligram? Because you get a milligram of epi, right?
Yeah,
so then it's just one, and then it's like an amp of bicarb or some crap like that. Whatever those, it's like, because y'all, like when you take ACLS, it's like kind of like a protocol you already go by anyway.
Yeah.
So like if you're ACLS certified, technically you don't need an NP or a doctor to run a code.
Yeah.
We've done it before. We've done it before. So it's just like everyone goes by the same standard. Yeah. So yeah, why not already have them preset? Damn. Someone's going to use our idea. Or someone has to have thought of that before.
Yeah, there must be a reason why it's not being done. But who knows?
But I'm like, but in some facilities with insulin, they give it to them already with the amount.
Yeah, like regular insulin?
Yeah, or like Lantus and stuff. That's how I used to give it at my old job. It would be like 30 minutes and they already have it drawn up for you. You just scan it. But with Lispro, we had to do it ourselves.
Draw it up.
Yeah. So I'm like, why wouldn't they do that?
I'm dead ass about to look that up because we're not trying to stay bedside this long.
No, and I'm trying to figure out what's going on with that. It has to be a reason.
Yeah.
Okay, would you rather be a charge nurse or preceptor? She does both.
I do both, but
actively.
Like I would have said preceptor, but then it's like precept who? I need to know that first. I think I'd rather do charge.
I think I would rather do charge.
Yeah. I just hate, like, again, it depends on who you have, but I hate having to explain my every little step while also trying to, like, keep up with the patients. You know, in the beginning when I still have to, and then if you're precepting like an experienced nurse, you get pushback if you try to tell them this is how we do it, and they'll be like, well, this is how I do it. It's like, okay. So
calm down there, Tiger.
What are we going to do?
Do what you want to do. It's your license. How about that? But I'm just telling you what we supposed to do here. Okay? But I feel like I'm babysitting. And it's like, you have to kind of keep up with everything that's going on. Like, you have to know everything that's going on, and then you have to watch them too, see if they're doing it right. But then you got to let them try to learn how to do it right. And
so
it's
you have to let them make their mistakes without really making a mistake. You know, because you don't want them to actually screw up.
And then you can't be critical because you got to care about people's feelings. So it's just like,
yeah. I don't know. I think my type A personality likes being charged.
Yeah, because I'm like, actually, you've precepted more than I have at this point because she be precepting back to back. Yeah, I'm not
coming.
See, I don't, but I think I've charged more than you have. Yeah. But I'm like, heck no, like charge. It's like being a resource nurse for the most part.
Yeah, yeah.
So, and especially since at our facility, or my old facility, they didn't have.
You still work there.
I'm still one of them. Yeah, I'm still one of them. I've not left completely, but they are free charges. Like where I'm at now, or where I've been for the last couple of shifts, it's kind of normal there for the charges to take full assignments.
That's insane.
Yeah, I do not agree. I'm like, how do you charge at that point?
No, you're not.
You can't be.
You're charged if you have time at that point.
No, literally. So I'm like, so what is the manager role at this point? Because some of the charge nurse duties probably have to follow the manager at that point. So it's very interesting. I've not yet figured it out. But every time I go on a different unit, I'm like, so what y'all do here? Like, how do we text? Like, what is the nurse to patient ratio? How high up do y'all go?
For a problem?
Yeah, I need to know because I'm like, I'm not trying to be like, oh, this girl, she doesn't know. Let's just give her another patient. Nah.
Yeah.
Y'all know we do four.
Especially as a float nurse, you can get the short end of the stick and you gotta...
Yeah, I've been asking every time. I'm like, how many patients do we get and how many texts? And I need to know what to expect.
You would think that since you're working for the same, like...
System,
it would be sort of streamlined.
I thought so too, and I thought a lot of stuff would be like basically identical, but it's not necessarily.
But is it the same for like the hospital itself?
I don't know because their units there are so specialized.
Oh,
like they have we just have med surg and it's just like everybody.
Yeah.
No, it's just like okay, it's med surg, but this is like ortho type patients.
Okay.
So it's like specialized like that, and then it's like
so then they have their own like rules.
Or what documentation they deem that's more necessary or more critical than the others.
Right.
Like they have to document the STDs and incidence parameter used.
Right, that would make sense.
Yeah, and like if they work in physical therapy, and it's just like each unit is med surg, but it's just like what type.
Right.
Because it was another surgical floor I went on, and they just did the cardiac surgeries in the thoracic.
Oh, that's kind of cool.
Yeah, they're broken. Like they're
really specific.
Very, very much so. So it's like, oh, this message, but I'm like, I don't know nothing about no external pacemaker. What is that? What does it look like?
I don't want to touch it.
Yeah, I was like, show me what it is. I was like, how do you know what to do for each surgery? Blah, blah. I said, I only know heart cath. That's it.
Or the TR bin.
Nothing else. So she was like, truthfully, she was like, it's so many different kind of cardiac and like thoracic surgeries that literally you just ask the surgeon, like, what do you want me to do?
And I assume they wouldn't give you anyone that's like freshly post-op either.
And I think they stay and pack you for a good bit of time. So they're normally stabilized by the time you get up to the unit. So it's more kind of like checking the sites.
and stuff. Okay.
Mm-hmm. So I'm like, we'll see how that goes. I'll keep y'all updated. So now we're going to get into the tea of this episode. We were talking about RaDonda Vaught. I don't know if y'all go like our opinions on the matter, but honestly, me and them are pretty problematic. Yeah, very, very opinionated. And I definitely wanted to talk about this because it's funny because when I was going through like my topics, anytime something happens at work, I like put it in my notes of stuff I want to talk about. And one of them was medication errors and should nurses be reprimanded. Like literally I already had it typed out like that. Yeah, and then I found out about this and I was like, right. And I was like, who am I going to talk about this with? And I was like, I'll talk about it with Noah. So yeah, I want to talk about that because it's just, it happens all the time.
Yeah.
And this case is like very juicy.
Yeah.
So I was like, it must be discussed. It has to be. So we're going to kind of go into this episode, you guys. I don't know how organized or unorganized it's going to be, but we're just going to go with it. We kind of have a format already.
We'll see. Put
together, but we'll see how much we actually adhere to it. So hopefully y'all get something out of this. But first we're going to start off with kind of just like a broad scenario. Summary of what occurred. And then we're kind of going to go more in depth for people who have like no idea what this case is about. So it's about this nurse, RaDonda Vaught. So she basically incorrectly administered Vicodinium. I don't even know how to pronounce that medication. Mm-hmm. It's a paralytic instead of giving Versed, which is a sedative, and it resulted in the patient death. And this happened all the way back in 2017. So now we're going to get into the tea. Me and Nona have looked at a lot of articles, so y'all didn't have to. Because it's like we were saying, it's so many articles.
Because there's a lot of conflicting stuff out there. I feel like there's a lot of biases out there too, depending. So,
So let's just start from the beginning because we were kind of like, dang, this happened all the way down in 2017 and now it's like 2022. What happened? So, I don't know. You kind of give them the first little part that you were telling me about.
So, it was an NPR article that I was reading and basically... Vanderbilt's not innocent in all this. So basically, from what they're saying is that Vanderbilt did kind of cover this up. They reported that the patient's death was of natural causes, which this is not a natural cause. They also, the article said that they were supposed to report this to the state and like the, kind of like the state and local level, I guess, since it's like a medication error that caused death. I guess I didn't know that you were supposed to do that, which they didn't do. They pretty much were trying to cover it up. From this article, they also said that they had a settlement with the family to kind of get them to like not press charges, kind of keep it like under the table. But then there was an anonymous person who somehow brought this up like a year or two later, and that's why it all got brought to the surface. So Vanderbilt was being shady about this too.
From the beginning. Yeah. And then I also was reading, and we're going to put all the articles in the description box, and if y'all have anything else to add, because like I said, there's so many things, it's kind of like you're trying to piece together the truth. So if y'all have anything to add, definitely comment down below. We're not saying like, oh, this is just what it is and that's it. No, like we said, we think this is what it is. So I also heard too and read that Medicare and Medicaid basically did like a surprise investigation. I'm guessing from like what Nama said, it was because someone had said something. Right. So they were investigating what was going on, and that's when they found that out. So what happened, to my knowledge, is that, because that's, like you said, varying information. This is an ICU nurse, and she had an orientee with her, from what I've read. And I'm going to tell y'all both sides that I've heard. So I've heard that it was a patient going down to MRI, and she was very anxious or whatever. So they prescribed Versed, which is sedative. And so basically, she administered to the patient what she thought was Versed at that time. Now, I also read too, I lost my train of thought what I was trying to say that. Oh, I also read too that actually wasn't her patient.
So, quick question. Was she the orientee or was she the preceptor?
No, she was a preceptor.
Oh.
But I read also that it wasn't like her patient too. Like she was giving it for somebody else. Yeah.
Ooh. I also read somewhere that she was still like a relatively new-ish nurse, unless I'm reading that wrong.
I didn't look how many years of nursing that she has. She's gonna look it up while we keep talking about this. So I've read in some places that it was her patient going down for the MRI. And I've read some other some other articles that said that it necessarily wasn't her patient. It was just a patient that she was giving the medication to, which is typical in the nursing world.
All the time.
Yeah, we'll be like, hey, I'm busy. Can you give this patient this? They're going for that. And then they'll just do it and then it's scanned under your name. So you do have to assume responsibility when you do that. Like that's on you as a nurse to kind of follow up like, hey, I'm just trying to make sure I'm understanding this correctly. So that's what I got out of that. So also found out too that they were in the imaging room, not like we're on the floor still.
Oh, so they were down in MRI when she pushed it.
Yes, because that does make a difference, and I'm going to tell y'all about that in a bit. So normally, sometimes we'll wait till transport comes, take the patient from the room on the floor, and give them the medication there before they go down to MRI. From what I read in the articles, and like I said, I'll put them all in the description box, the patient was already in MRI, and then she went down there with the medication, and that's where she administered it.
Which you don't have a lot of resources down there.
So exactly.
You're kind of screwed.
Exactly. So I'm saying that because of what I'm about to tell y'all now. So did you find out?
So I found she graduated nursing school back in 2015, and this happened in 2017.
Oh, so she still was relatively new.
Less than 2 years.
That's still relatively
by the time
new.
she got her license, because you need to graduate.
Oh yeah, so she still was a relatively new nurse.
Oh, yeah.
Yeah, okay. That does make a bit of a difference actually. But so what happened? We're going to tell y'all what happened and like what normally would happen, because this is not normal circumstances. Yeah. So from what I read, she was going into the Pyxis, and for those who are not familiar with the medical world, it's basically this dispensing machine, kind of like a vending machine with medications in it, to put it plainly. So you type in your ID, put your password in, or you use your fingerprint, and it opens up. You can go find the patients. Like, you have access to all the patients on your unit. You pick the one that is the one you're looking for, and then from there, it tells you all of their available medications, and then they even break it down to like scheduled or like you give it as needed. Right. So then, like, it's either going to be on there, or I don't know, in some situations, like emergency circumstances, you have to override the Pyxis, and then you have access to all the medications, like in the entire Pyxis machine. So that was the case with her. For some reason, they were saying it was common practice at Vanderbilt. I don't know if there was some type of system error going on.
I think from what I was reading on the NPR article, it was they were just having this ongoing issue with the system, with the hardware. So then it almost became a common practice because it wasn't being taken care of. So it's not like something that it's not like something they should have been doing. It's something that should have been fixed, so that something like this wouldn't have happened.
Right, so like what Num is saying is kind of like, it's not like the nurses are just like all normalizing the practice of overriding medications. It's like, no, they literally have no choice but to override the meds. Yeah, so when that happens, like I said, you have access to all the medications in the whole Pyxis machine. So you have to type in the name of the medication you want. So some Pyxis are different. Some of them pull up both of like the medication based off of the generic or the pharmacological name. I think in this case, hers only did the pharmacological name because she typed in VE, which, you know, the first two letters of Versed, and she didn't see it. So like she tried to do it again. I guess she didn't know the pharmacological name of it. But either which way, she typed in VE, and then that's how she ended up pulling out the coronium. Golly, the coronium. I don't know. This is a horrible name. Every time I see meds, I'm like, the people like who did I'm like, are these the creators of Harry Potter or what? Because I'm like, I don't understand. But anyway, she pulled that out too. I mean, instead. So apparently when this happened, pop-ups on the Pyxis like screen said like, hey, it's a paralytic. Are you sure you want to like withdraw this medication? And for certain meds, they do this. They insulin, pain, I think they do that. They'll
like Ativan and stuff.
Yeah, they'll ask like, how's the patient? Are they alert oriented? Yeah. So normally kind of like higher risk medications do have pop-ups that'll ask you some information about it. So basically she just pressed accept or agree or whatever it was so that she could get the med out. And then after that...
Oh, sorry, but you know one more thing I'm thinking about? Anytime I have had to override like Ativan, like for a patient who's like seizing and we didn't have it already ordered, it does require you to have a witness sign off.
Did it? Okay, because I've never overrode.
Because I'm thinking if something as like serious as zirconium, like I would have 110% expected there to be like a witness.
That's true.
So I'm wondering where
and you know too, they set the Pyxis machines up how they want it to be. Like, I guess the facility.
Oh.
Because at my old facility, we had the same Pyxis machines, but we didn't have to, like for insulin, it requires a cosign. Whereas when we used to work, it didn't.
Yeah.
So it's some way that they get.
So I guess it's not all streamlined.
Yeah, it's some way that they get with the people when they set up the Pyxis machines in order for that to take place, because we actually had changed Pyxis machines at my old job. And they were telling us about like the new updates and what to expect. So there they had it set up for insulin to have a cosign, and like where I used to work, it doesn't do that.
Yeah.
So I don't know who's responsible for that.
Yeah, that's interesting.
But yeah, that's not like a standard thing. So that might be part of the reason why that wasn't even like that.
That wasn't a thing.
Yeah.
Then you would expect there to be 2 nurses on this trial, right? Because you're just as, like, if I sign off on something that you're giving, I'm taking as much responsibility as you are for pushing it.
Exactly. So it didn't have the witness, and some people did bring that up. But it didn't have that for this medication. And then she ended up administering to the patient. So we're kind of going to go into like, I guess the red flags you would say. And there's a lot of red flags. Some of them I didn't say yet because y'all can grasp the picture now. But yeah, we're going to go into like, how did this get here?
How did it get here?
How did this happen? So what do you think, Nama? Like,
well, one, I think that there should have been that witness, because that witness sign off would have stopped her. Because I mean, if she doesn't know something, she doesn't know it, right? So if she doesn't know that Versed is, I don't know how to pronounce it, midazolam, whatever.
Yeah.
And she sees the first VE thing, and in the back of her head, she's probably thinking like, oh crap, I need to give this now. They're about to start this MRI. So you're already kind of like in this panic mode. And then, if you're not thinking right, and then of course you're going to pull it. But then again, seeing the, what's it called? The pop-up saying this is a paralytic, that should also tell you like, I'm not trying to give a paralytic right now. Why am I giving a paralytic? So that right there is also the thing that's like, well, why didn't you think twice about that? But I don't know. I'm trying to see if I can blame this on anyone else.
It's a lot of things wrong here. And one of the other things I didn't mention is that Versed is like a liquid, and then the zirconium or whatever, you have to constitute it.
So if she's never given that before, she might not know it. But then
if she's never given Versed before, because you would have to know what Versed is like. Yeah.
But I'm also wondering if you said they were down in imaging. I'm thinking, was there not any other provider down there? Was it just like the imaging team and her?
It had to be, because I'm thinking of when we go down for imaging, there's nobody down there.
But then who was the order already like verbalized to her? Like, hey, when you get down there, we need to give this. Like, who even gave
those details? I'm not even sure about, because I'm like, it could have been like a PRN, because we've been in these scenarios before, so that's why we're kind of trying to think about it. Because there's some that like the PRN order is already there, like literally give before the MRI.
Yeah.
And then I've seen it before too, where it's kind of like, they're calling you and the patient is panicking, like, we're not gonna be able to do the MRI, can you get an order?
Yeah.
And then you call and get the order like that, and then you put it in.
And it's all verbal, and then
and you put it in. Yeah. And even if you haven't given it before, then you still wouldn't know.
Right.
So it's just kind of like, what are the circumstances surrounding this? That's why it's like, it's very interesting case to discuss, because there's a lot of moving parts and a lot of people involved. Before we even get to the part where she like killed the patient.
Yeah, we're not even.
We're still at the Pyxis room.
Like,
how did this get here? So also for those who don't know, they don't have Pyxis machines down in the imaging department. You have to get it from your Pyxis on the floor and then walk there. So, because before, when I was thinking about this case, I was like, why she even scan it? Because that was another thing. They were saying like, oh, she didn't scan the med.
And that's the thing. Was it even ordered, or was it a verbal thing?
See, and then what I would have done, if it was verbal, you put it into the computer anyway. I want to put it in first, but I mean, technically, we would have done it to be able to pull it properly. But since they were overriding everything anyway, it wouldn't have mattered if it was in the system.
Yeah.
You know what I'm saying?
Yeah.
You don't need
to automatically do that anyway.
Yeah, it doesn't need to be approved by pharmacy.
Yeah.
Because normally what we would do, guys, is that we'll get, even if we got a verbal order, we'll be like, okay, I'll put it in, we'll type it into the computer. And if she would have typed it into the computer, she would have known probably the pharmacological name. Because both of them pop up.
Yeah.
Both of them pop up when you put the order in.
And either way, the pharmacist might not have even like verified that. Because that's another little checking point that you go through as a pharmacist, which we like didn't do because it wasn't put in.
Yeah, so I'm guessing it was not actually put into the system for her to technically give, like in the charting system. That would make sense. But even if it didn't, it wouldn't matter because she still had to override it out the Pyxis to get it out anyway.
Yeah.
But at least then, if you would have put it in, or if you would have saw us put it in, you probably would have saw the other name for it in that instance. But back to the scanning part. See, I've done that before. Literally, I've done that before. I went to the Pyxis machine and pulled something out and walked to Imogen. But I scanned it before I went down there.
And also, I'm thinking, like, this isn't a emergency situation. It is like, what would you call it? Like,
more like urgent.
Yeah, urgent, but it's not like an emergency. So you can take the like extra 30 seconds to put it in the system and order it and then pull it out. Because it's not like a life-threatening thing happening where you just don't have time for that.
Yeah, and that's another, I guess, red flag. Because, I mean, and I didn't want to talk about that because I feel like sometimes as nurses we put too much on ourselves and not enough on other people. Like, because everybody else puts stuff on us. So we're just like, oh, I have to figure it out, I have to get it done. But at the same time, it's like, nah, fuck y'all. Like, it's my license, bro. Like, nah, y'all gonna wait. You know, because see, the imaging people not being called up. Nobody else is being called up. It's the nurse. It's always the nurse. So I'm like in my older toddler ages of being a nurse. I'm like, no, like, I'm gonna do it the right way and y'all just gonna have to wait and I don't care if y'all are mad or not. Because that'd be the other thing. Like, people push back on us so much.
Oh, yeah.
Like, oh, we have other people to do. We have a stroke patient down here. Can you hurry up?
Yeah.
Blah, blah, blah. Like, if you don't do it now, then they're not gonna be able to get it done for today. Because we've had that before, too, at our job.
Why wasn't the order already in? Like, you're asking me as if it's my main responsibility to put in orders. It's absolutely not. We're not supposed to be doing that.
Yeah, technically, we're not even supposed to be putting in the orders. The doctor is. So let's just start there. But on occasion, we do put it in. Actually, I'll just be honest, more than occasion, we'll put it in. And it still has to be verified and stuff like that. But technically, they don't want us to have to do with that at all, I guess, for some instances, cases such as this. But back to the urgent versus, like, kind of stat thing. It's kind of like, I don't know, I think it's because you don't want to get yelled at, you don't want to get cussed out. Like, literally, this is how it is, like, in the work environment for us. It's like, okay, let me hurry up and get this done with so they can leave me alone. And I have 4 of the patients or whatever. In this instance, she's ICU, so I'm guessing she probably had 2, 3 if they're short. Yeah. But still, that's still a lot for ICU nurse. So it's just like, dang, girl, like, you know, sometimes you just have to be like, y'all don't have to wait.
Yeah. And I mean, I feel like the least experienced you are, you're not going to be comfortable to slow down and push back and say, hold on, I need to like put the order in.
That's true.
I think when you're like a new nurse, you're doing literally anything anyone will tell you. Yeah. Even if it like comes at a cost to you.
Yeah, I can agree with that.
Something that happened.
And I think too sometimes that newer nurses don't even realize like what the cost to you is. Yeah. Like I think they're just like, kind of like you said, it's like everything has to be done now, like now. Like I think I used to be like kind of like that too. As soon as I saw a new order pop in, I'm like running in the room to do it. Like it's just like that's just not how nursing works. Yeah. And the pandemic helped me with that because it's like they used to press on us. You have to give the meds in a certain time frame. you have to do this. And it's like, when pandemic hit, it's like, oh, you really don't have to do none of that at all.
Just keep them alive.
Right, yeah, it's just like, that's not what's important.
I think the pandemic helped us realize that all these like rules are kind of bullshit at the end of the day.
Arbitrary. Who made this up?
Yeah, and that's why it's kind of like been relaxed a little bit, even though they're trying to get back on it. But I feel like as nurses, everyone's kind of like, no.
Yeah, because I used to
managed for 2 years.
I used to be one of the ones like it has to be given at this time. Like it's ordered for this time. I have to give it around this time. Blah blah blah. And yeah, I still try to keep to that because that's the time it's ordered for. And they space out medications based off of the reactions with others. Blah blah blah. Drug interactions. Blah blah blah. Antibiotics have to kind of be given at a certain time. Yeah, but it's just like some stuff like that Colace. Baby, that Colace don't matter. That Miralax. No. I mean, unless they ain't pooped in like a week. Like, I mean, it's not that deep. And then, like, we be breaking our back. So it does go to that point. She could have, if she didn't feel the pressure from the system on her necessarily, she probably would have taken the time out to do some of those things we're thinking like you should have done. But us being more experienced nurses, we're kind of just like, I don't care if you're waiting on me. I don't care what you're doing. I'm doing it anyway. I
don't care if you have to reschedule.
The MRI. Right, exactly. Like, I'm doing what I got to do on my part to make sure it's safe. So I definitely think that was a contributing factor.
There's a lot of factors to this. It's not, the blame is not only on her.
Oh, it's definitely not. Definitely not. But mother, and then it's just that we brought up the experience too, because like you were saying, and a lot of other people were saying too, they're kind of like trying to question like her knowledge of Versed. And it's like, now that I know she's like a 1-year nurse, maybe she didn't know that Versed was constituted.
Yeah.
And I can't say what other people would do. I know what I would do. But I told y'all I don't care. So it's just like, I'm going to be like, where's this drug? Let me look it up.
I would have been, if I got verbal orders, I would have literally told them, I would have wrote it down. Especially because you need to know like the exact dosage you're giving, right? If you're going to be pulling it up. So I'd write it all down. And I feel like when we do give those like high alert medications, a lot of times we're saying like, hey, I got 2 milligrams of like propofol.
Right.
And like, you know, right when you're about to get it, you say it out loud. It's not like you just quietly do, I don't know. But then again, there's no provider down there with her.
Right. So. And then she's in ICU, so I don't even think necessarily our Pyxis even have access to some of those drugs. No. Yeah. Like, ICU nurses have access to a lot of drugs. And I think, too, I mean, at the end of the day, some of this stuff does fall back on her nurse. Because it's like, you have to kind of take, like, you can't be, I don't know what's the word. Like, you just can't let people push you around, basically. You have to do your checks.
Yeah.
Like, because if you're in ICU, it's already a high risk situation. Like everything is high risk, not like med surg. We'd be like, oh, they're fine. But it's like, so you definitely have to double check, like, what is this medication? So if you didn't see Versed, then you should have been like, dang, what's the other name for Versed?
Yeah.
There's many a times I've looked up in my phone, like, what is this drug?
Real quick, yeah.
Yeah, or you click on
before you give anything.
The chart and you'll click on Lexicon.
Yeah.
Yeah, you're like, what is this again? Like, and then in those instances that would have caught her, like she would have caught it at that point. So it's just like so many cracks. And people do talk like, oh, at any point she should have caught it. But I'm like, that 1 year or 1.5 year,
like
it really did make a difference because she doesn't know a lot at that point.
She doesn't know what she doesn't know.
Right.
And like you can kind of blame her for stuff, but then you kind of can't. Because you don't know what you don't know. It's a very like weird situation.
Exactly. I just know how anal I am. So I do double check everything. So I'm like, I can only speak for me. I can't speak for other nurses because every nurse practice is different.
Yeah.
So it's like, I definitely would have been like, I'm not putting this drug in because it's a sedative. You got to put it in, first of all.
Right.
I probably wouldn't have even put it in. I don't know. Or like, Nama said, well, I wasn't this put in earlier. Now y'all calling me to do, like, get the MRI later. But once again, you're in ICU, so it's higher risk. So it's just like, because you know it's high risk.
Yeah.
Me as a nurse, I would have been like, all right, let me really make sure that this is what it says it is. And if you're going down there to give it, ain't like nobody watching you give it. And she has the orientee on, but what do they know if you don't know?
Like, you're just holding your flesh.
They don't know any, unless you have one of them little book smart ones. Some of them do know.
Of them, yeah.
They're like, I thought this, whatever. Yeah. And you're like, bitch, you don't know what you're talking about. Are you looking up and you're like, oh, you right, never mind. Like, so, I guess let's get into these contributing factors, because you had said that it's like a lot of stuff that plays into this. And it's like, it's her fault, but it's not her fault at the same time.
Mm-hmm. Sorry.
Sips tea.
No, like what I said in the beginning, Vanderbilt covered this up. So not only should they have, first of all, fixed this issue so that overriding wasn't an issue.
It should start from there.
They were being hella shady after this patient died. According to the article, they put that the cause of death was natural causes. They did not even mention zirconium anywhere in the cause of death, which we clearly know is the cause of death. That was not natural. So they're already being shady about it. Like, why? And then also, why aren't they getting prosecuted for it? Like,
yeah, I'm like, who? I want to know. And then I feel like a lot of things should happen, because it's like, yeah, the hospital should be reprimanded. The people who was doing this Pyxis thing, like, who was the one delaying this? Like,
right, IT or whoever.
Yeah, I'm like, how did it go on for so long? Like, a mistake was bound to happen with that type of situation, honestly. And as much as I want to blame them too, at the end of the day, everything does fall back on us. So that's why I kind of be trying to tell people, like, be careful. I mean, that's why cover your ass is a thing in nurse. Yeah, chart, like, cover your ass, because we get blamed for everything. So, I mean, unless you didn't have a good teacher, somebody should have told that girl that. Like, you have to, like, take the extra step, because, I mean, this case proves them people, we haven't heard of them getting in trouble. It's the nurse that lost her license, her job, and years off her life.
And I mean, and the company she's working for is, like, putting their hands up. They're not going to protect her because they need to
they're not even, like, people aren't even making statements. Like, no. I think it was some type of nurse educator or something had made a statement on her behalf to say, like, kind of like, yeah, it was common practice that we were overriding medicine. Like, that should have never actually really been a thing, like Nama said. The opportunity should have never presented itself for that to happen. So I do blame the environment too, but at the end of the day, sometimes you can't help your circumstances. You can only
do what you can do.
Right, in those circumstances. So with that being said, like, I think, okay, we said, like, imperfect protocols, basically. So that definitely, with the Pyxis machine, and then non-normalizing overriding, which is supposed to be like last resort type of thing. What else do you think kind of like contributed to that? Like the downfall, I guess, of her making all these mistakes?
I mean, you still have a provider over you as a nurse, whether it was ICU NP, whether it was ICU doctor. I mean, like, why aren't they in the picture?
Yeah,
right.
That's true too.
She didn't think to give this all on her own.
Yeah. So we have questions too, like, who, like, was the order even put in? Like, because that's what we really don't know. They didn't give us those details. So, like, was it put in? And if so, if it was her putting it in, why didn't they put it in? And that's supposed to be a provider responsibility. So there's that. And then also, I guess, too, like, contributing factors, like we mentioned before, too, is just kind of like the pressure that they put on nurses to perform. Like, a lot of times, like, it's a lot of players involved, but everything comes back to the nurse, like, oh, but what are you going to do about it? And it's like, this is not my area of expertise, but I guess I'll figure it out.
Yeah.
I don't know why it's like that. We're, like, attached to the patient, and we have to figure everything out for the patient.
Yeah.
And we're kind of like the in-between person, like, oh.
Definitely the middleman.
Yeah, like, let me talk to case management, and let me talk to the doctor, and I'm going to talk back to the patient. And it's just like, why am I?
Why can't you all talk to each other?
Why am I doing this? Like, I'm not understanding. So I think that too, I felt like what Nama said with it wasn't as urgent. Maybe she wouldn't have felt the pressure to do it so quick if that was the case. Had it, like, if there's less pressure on us as nurses in general. Because I'm like, if she was like, we know now because we're like older and like more experienced. But as a newer nurse, you do feel like that expectation to perform. So I definitely think that's a contributing factor. And then, I don't know, some people are trying to blame her being distracted by orientea, but I'm just kind of like, I don't know about that.
I don't know. At least every time I've had an orientea, and if there's an emergency situation happening, I don't even see my freaking orientea let me take over. Like, get out of my way. Like, no, you are not, no. Like, I don't, for me at least, I'm just like, move.
I don't know. For me, I'm like, the orientea actually helps me do better, because I'm like, let me not like cut corners or do anything else, because I really want to show them like the proper way to do stuff. So I think they kind of keep me more on the straight and narrow, because it's like, okay, let me actually like do this how they say in the book. So like I'm teaching them correctly. So if anything, I'd been like, y'all not supposed to override, but this is what we having to do right now.
Right.
And then I would have been taking the time to be like, okay, so since we having to override, let me make sure this is the right med, and blah, 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 blah.
But in that moment, who knows if the orientee was even with her? Like, let's say
that's true too.
Let's say she told the orientee, "Hey, stay up on the floor and watch our other patient while I go down and do this."
And that could definitely happen. That's true. Yeah. That's definitely true. So this is so interesting, because it's just like, who's to say exactly what the day was like? Because we've experienced this day so many times in so many different ways. So it's just very interesting. So I guess like. So what happened after people got involved? Her license, obviously, she didn't have anymore. She got fired. And then as far as charges, she was indicted in 2019 on reckless homicide and impaired adult abuse. So do you agree with that, or what do you think?
No. I mean, I think that's, okay, I would say this was neglect. Right? Neglect to like double check, neglect to, you know, kind of do all that. But I don't know. I feel like that's a little much.
It sounds like a lot. Okay, so it says she's facing 3 to 6 years in prison for neglect and 1 to 2 years for negligent homicide as a defendant with no prior convictions. And she's going to be sentenced in May 13th. And they're saying likely her sentences will run concurrently. So I was looking up, I'm like, what the hell is, because they keep interchanging words like reckless homicide, negligent homicide, and criminal negligence. So I was like, what is that? So when I looked it up, it says criminal negligence / negligent homicide is the failure to use reasonable care to avoid consequences that threaten or harm the safety of the public and that are the foreseeable outcome of acting in a particular manner. So in that case, I do agree. I'm like, I don't know if she should have to necessarily go to jail, but is she guilty? Yeah.
To a certain extent.
Right. And that's not saying that other people are not guilty as well. Charge them all, I say.
That's what I'm saying. I feel like the provider, the doctor, NP, whoever, should also get a little bit of something for neglect, because that on their part for not putting the orders in or whatnot.
Yeah, so I'm like, but at the end of the day, I'm like, I'm not even sure what everybody else's part was in this, since they didn't make it public. So the only thing I do know is the stuff that we said we probably would have done is like double checking this. Like if I'm not sure, I always double check everything. So it's just kind of like, even if I did feel pressure, like when I was younger, less experienced nurse, like I said, I'm not everybody else, but I still be like, well, I don't know what that is, so let me see, or I'll ask the charge, like, oh, hey, like, can you do this, or like, what is that? Yeah, and then it's just kind of like, so at the end of the day, I'm kind of like, I do think she is guilty of negligent homicide. I don't want to like, it sucks because it could literally be any of us, but that's just literally how serious our job is.
That is literally what happened, though.
I'm like, yeah, because I'm like, how can you not, like, the override should have never happened, but it did happen. So that's why I was saying sometimes we can't control the environment we work in, but we can control what we do in that environment. So since you knew that y'all have been having to override everything, you need to be extra precautious, because anything can happen. Every time I go to work, I think like I could kill somebody, or like somebody could die. Like cause it just puts things in perspective, because I think a lot of nurses get lackadaisical in their nursing care.
Yeah. Like I feel like eventually, you can see things enough and then in the back of your head go, oh, that was no big deal. Like nothing happened to the patient, until one day something does happen to a different patient.
Yeah.
Like, I don't know. Like, okay, like let's say, for example, like these PRN blood pressure medications that will just be like pumping through people and their blood pressure still like sky high, and you kind of don't think about it. Like, and you're probably thinking with this next little patient that I can do the same thing and nothing's gonna happen. And you turn your back and she's tanking. So it's like, I feel like when you see it enough, you kind of get like desensitized.
Yeah,
certain, alerts. But yeah, so it could have been that too.
Yeah, and that's definitely a contributing factor. But I just be feeling like it's an excuse. It can happen and it's understandable, but with the type of profession that we took on, and like, I don't want to say we knew what we getting into, because some of the stuff we didn't know we were getting into.
I don't think anyone knew we were actually.
We didn't know like the circumstances we were getting into, but you knew like you have the power to affect somebody positively or negatively. And I mean, it could go any way. So it's just like, you do have to be extra precautious, and you do have to do your assessment even when you don't want to, because you might catch somebody else. How many times have we caught shit, Nama, that the previous shift did not see? Like,
you're fucking kidding me.
Like almost every time we work, right? So it's just like, I don't know. It's just like, it's hard to say that. Like, I don't want, like, it's just kind of like, damn, I do think you guilty. I think a lot of people are guilty. So I'm just like, it sucks that it had to be her, but it was bound to happen. And I know it happens all the time. So it's just, I guess the debate now is like, should nurses be charged with like jail time, I guess, for like errors such as that?
Yeah.
I'm kind of 50-50. Because honestly, I think it's not the good nurses that are going to get in trouble as much. Sometimes you might slip up and make an error. But I feel like if it's like an emergency situation, like a cold or a rapid, I'm literally, those are high.
Those are those moments where you actually don't even have the 30 seconds to pull out your phone to look it up.
Right.
So yeah, I mean, I would say that because like I try to think about it as if I was like the family member of that patient.
And that's what I think about too.
Like because as a nurse, I'm saying, oh, she shouldn't get jail time. But then if that was my family member, then I'm kind of like, you know, I need someone to like. I need something to kind of like...
Somebody needs to be held accountable for what happened. So somebody died at the end of the day.
Yeah, and it was like your family member. So then it's like, I don't know.
I think too, like, even me just thinking as a nurse, because I've seen so much shit at that job we worked at, I'm like, hell yeah, charge them nurses. Because I'm just like, the shit that we be seeing, y'all, I've told y'all some of this on some of the episodes. But it's just like some people, it's just like, how are you still here? How are you still have a job? It's just like, I don't understand. And if that's just happening on our unit, I'm like, what's happening everywhere else?
Yeah.
So I'm just like, think of like when I'm the patient one day. Like, it's just like, what the whole hell? So I feel like, because a lot of people are like, oh, you know, this is going to be bad for nurses everywhere. And I'm like, but some of these nurses suck ass. And I need them to have
this is a wake-up call. Hopefully.
Yeah, like, I'm like, I need them to have fear in their heart. Like, you need to double check your patient. You can't just be giving blood pressure medications and not knowing what the blood pressure is. We see that shit every day. Like, literally every day we see that shit. Like, crazy shit that we be like, dang, you just go give them that? Like, are you sure? Like, you're gonna do that? And it's just like, are you sure? But it's just kind of weird because we have our own patients, so we're like practicing separately. So it's just like, you see it, but it's just like...
It's like, damn, okay.
You're just like praying for the patient, like, I hope you good, bro. Like... Like, how many times we got patients with all them down, pressure ulcers? We know we changed the dressing. Right. Do we know if the other people did?
No.
I don't know.
I still see my little dated little Mephilex back there.
Yeah, I'm like, are they turning them? I don't know. That's what they said we're supposed to do. It's a lot of shit not being done. That's all I gotta say. So I'm just kind of like...
That's a whole different conversation. I feel like for a lot of reasons. Like, one, just being a lazy nurse, but two, just like understaffing. That's like a whole different issue of like everything on our plate.
But that kind of goes into this too, because it's just like, if you want to generalize the medication errors, because a lot of them can happen because of understaffing, short staffing and stuff like that too. But it's just like, at the end of the day, like I said, you know, you have responsibility as a nurse. Everything is not life-saving measures.
Yeah.
So it's just like, when you doing, like, you have to learn how to prioritize. Like, some stuff is not going to matter and you're not going to be able to get to. But then it's like some stuff is like, you have to do this shit. Like, you can't just skip like, oh, that dressing on that central line look a little ugly, but you know.
I'm just put more tape on it.
Yeah, like it's just like some stuff is like, you had a fever, but you'll be alright. Like, I'm not gonna tell anybody or like, you know, like some stuff. Yeah, I'm like, it's some stuff that's just, I used to hate when some patients' blood pressure would be like super duper duper low, and they're like, oh, just wave your arm up and down so you get the right high. I'm like, but hell, if it's in the 80s, something is wrong. Like, what the hell do you mean? So it's just kind of like, what?
Yeah. That's a whole different episode.
But I was kind of glad. That's why I was kind of glad she did get in trouble. Sorry to Redonda for shaking one for the team. But I was kind of glad she did get in trouble, because I'm like, maybe other nurses would think twice before doing some of the stuff that they do.
Yeah, I mean, I'd hope so, at least at the end of this, that could be the one good thing that comes out of this.
Yeah.
But I'm wondering how the nurses at Vanderbilt feel right now.
Watch your back.
Knowing how shady the hospital was being.
I would have quit.
Oh, yeah. And like I was showing you, like there's this like someone posted that Vanderbilt is like putting out like 20K sign-on bonus for new nurses, but who the hell is gonna want to go work there now? You know?
They were shady for even like, it should have just been common knowledge, like, oh, it was a medication error, and then that should just been that. Okay, yeah, she could have lost her license, and that was sufficient enough. That normally is what happens. People don't normally get criminally charged, but. And that's not even on her part. She didn't try to cover, well, to our knowledge, she didn't try to cover shit up. It was the hospital that did that.
And I would assume that you're covering, the hospital, like, is covering something up because they know there's something wrong to be...
Yeah, that you need to cover up. Yeah, because why else are you covering something up? So you know something is wrong here.
Right.
Yeah, I definitely would have quit that job if I was one of the other nurses that worked there. But it kind of... See, and that's why I just said some of that comes back on the nurse, because it's like, I always think too, like, I'm so low down on the totem pole. Like, I can't change the situation here. All I can do is change my situation.
Yeah.
So you know, like, unsafe practices is happening and wherever you work, and you know, like, what you're supposed to do as a nurse. Like, you have to protect your license. That's half the reason why I left our job. Y'all ain't about to get me caught up in y'all bullshit. Oh, so let me and I'm gonna tell y'all while we're talking about the bullshit. The ICU class. Tell them about it. Tell them about it. Because this all kind of ties in together, like protecting your license and like your, I don't want to say your brand as a nurse, but like your reputation as a nurse, I guess you could say.
So this is when like COVID was really like spiking, and in our hospital, there's only 2 ICUs, one of which they refused to use for any of the COVID patients because they wanted to keep it clean for like the surgeries that would come in. And so they decided to turn our floor into like the IMU. So basically anyone who wasn't intubated would come to us so that they could keep all the intubated people there and so that they weren't so overwhelmed. So they made us sign up for this like ICU enrichment course. It was about like an 8-hour class, and we had a respiratory therapist. I mean, it sounded promising, right? They said an RT was going to be there, pharmacist was going to be there, and ICU NP was going to be there, and they were each going to like kind of like go over things that like we're not familiar with, like the medications and equipment and stuff. So it's like, okay, cool, you know, like everyone gets to learn something new. And then we get there, and then the RT, I remember he's like showing us how to put the BiPAP on and how to take it off, and then we're like, and then he's like, "That's it? You want to come play with it?" And we're just like, "Hold on." Like, how the hell do we troubleshoot it? How the hell do we, like, change settings? Like, how do we actually use this, like, machine? And I remember Lainey asked, and she goes, so, like, if something goes wrong, does it end up being on us? Right? Because we're getting this, like, bullshit-ass 8-hour class, and you're teaching us how to take it on and off. Like, you're not actually teaching us how to use it. So what am I supposed to do when the patient's desatting? Just... adjust the straps.
And then the other thing with that class too, guys, is that they like taught us about like drips, like literally ICU level drips, because I guess they are saying different things. Of course, that's how you always know there's bullshit around. The answer is not consistent. And one thing I'm gonna do is I'm gonna get to the bottom of the bullshit. So they're like, oh, like y'all are gonna go down to ICU, and then first they were trying to say we're gonna get like IMU level patients down in the ICU. So it's kind of like, why are they in ICU still if they're IMU level? Why not just downgrade them and put them on our floor? Mm-hmm. That's my first question. Second, it was kind of like, okay, you're gonna be buddies with the ICU nurse. First, anybody in nursing knows, and this is how you have to be around the block a little bit longer. Y'all are buddies. That girl or that guy is not gonna be there like that. Mm-hmm. Even if they really want to and intend it, like sometimes shit just happens. They're already taking care of like literally critical patients, and yours is like the less critical one. So it's like their priority is not going to be on you. I just know that for a fact. So they were trying to say like, we're going to have an ICU level patient, and they may be on a couple drips, but we'll have a ICU nurse coming around on them. Yeah, as a resource. And if something goes wrong, call them. My problem was when we start getting to the Levophed and everything else. I was like, I don't know those meds like that, and they're very sensitive.
Yeah, these are medications that you're literally titrating on a parameter basis up and down on the dosages, literally every, like, depending on the med, 5 to 15 minutes. Watching the the heart rate or the blood pressure change. So that kind of tells you how like sensitive these meds are.
Yeah.
And so, I mean, a lot of that class was bullshit, and then a lot of what we ended up learning was on the job when we straight up just got thrown into it, which in hindsight is incredibly unsafe for the patients.
Oh, definitely. So what we did is we did that class. They taught us about the drips, the airways, blah, blah, blah. But that all sounds good and nice on paper. But what does that look like in real life? Mm-hmm. And, like, it's completely different all the time.
It's easy to learn about, like, alpha-1, beta-2.
Yeah, okay. It's just like, oh, yeah, that makes sense. Yeah, but when you see it in real life, like, can you make the application? Like, you need experience to go along with that. So we did do a clinical, kind of like a clinical there, like, for 12 hours. And then that was it. So it's just like, what, a shift? And now I can, oh, no. Like, it's just like, what? And like Number said, I did bring that up. Like, who's gonna, like, if something happens, does that fall on my ICU buddy? Or does it fall on me? And she's kind of just like,
that's a good question.
Yo, you know what that means. Luckily, it never happened, but I told them if it ever did, I would raise hell. Y'all can send somebody else down there, but you're not gonna send me. Because it doesn't take any, like, people die so easily. Like, human life is so fragile. Like, it doesn't take much. I accidentally bumped into the IV pump and, like, bumped it up. Yeah, bumped it up 0.5 micrograms. Oh, here it goes. They're going down. Yeah, it's like, oh, no. Y'all aren't going to put this on me. My thing about it, too, I was kind of like, why do y'all have people who transfer, who've been nurses for years, and they're transferring to ICU? Why do you make them orient for, like, 3 months?
Right. How is that enough? To even see the whole, like, everything that you would possibly need to see down there.
Y'all make them orient for 3 months to, like, safely work on the unit, but you think that an 8-hour class and a 12-hour clinical is sufficient?
Yeah.
For me to take care of a patient?
And then they would also give us, an ICU nurse for, like, a couple of months. Like, one ICU nurse would come down on our floor and she would have a patient assignment. And typically, her patient assignment, or, like, his or her patient assignment would be lighter, so that they could be a resource to us if we had any questions, which only in my experience ended up backfiring, because then they were just like, well, this is a vacation. I'm just going to sit here and do nothing. Like, I don't want to help you.
Yeah, and I mean, like, who can blame them? Because, shit, they tired too. Yeah. So it's just like, okay, like, they're like, I don't think anybody has, like, ill intent, but it's just kind of like, if you could take a break, you take a break.
It was in the height of COVID and middle of all these surges, everyone was, like, over it and exhausted for a lot of reasons.
Yeah.
I feel like I learned everything that I learned through a couple good RTs who, like, helped me get comfortable with heated high flows and BiPAPs and why this means that, or what, like, kind of just everything. And then the ICU NPs, too. I feel like we learned a lot from them.
Yeah.
I really wouldn't say the ICU RNs did shit for us.
Yeah. I actually wasn't there when they transitioned. So that unit was med-surg first and then kind of transitioned, well, with COVID, transition for COVID IMU.
Yeah.
So I came after the transition and I already had IMU experience. So for me, I didn't have to go through that with Nama. Luckily, I already had, like, actual IMU, like, training. So it's kind of like, okay, that's fine, blah, blah, blah. But that ICU stuff, I was like, oh, no.
Because that was, they were like planning on trying to give us legit ICU patients and labeling them as IMU, which is just, that's the downfall on our hospital for trying to do that.
Yeah, that's not right. Luckily, it never happened. Because the fact that y'all thought, like, to even do this, y'all thought this was okay. Like, I was just like, this is unacceptable. So I was saying that it's part of the reason why I had to leave there. Because it's just like, I feel like you can do it once, you can do it again, something else goes wrong. So I'm just like, that's what I was saying. Like, sometimes you can't change the situation, but you can change the situation around you. Like, you can leave. Like, you don't have to stay somewhere where you feel like they do unsafe practices or stuff like that. Like, that whole overriding thing, either I would have been like super cautious. Like, I'm like, oh no, like, y'all gonna have to wait because since y'all doing this, I need to check everything before I give it to this patient. Like, I'm doing the 6 rights of meds and all that crap. Like, what is your name and date of birth? Like, I'm doing like everything to cover my butt. And I'm had to override this med, like,
because this person didn't put it in, so I put it in.
Yes, like, I'm writing everything down. So it's just either that or it would have just left. But it's just like, that becoming common practice is still kind of mind-blowing to me. I don't know, how could that have taken so long to resolve? Like, hospitals have money, they just choose when and when not to use it.
Oh, yeah.
But I guess, too, guys, we just want to encourage y'all, if y'all are nurses, like, look out for yourself before y'all look out for anybody else.
What do they say? Put your own little oxygen mask on before you help the person next to you?
Yeah, on the plane. Yeah, definitely. And I don't even know, how do we tell, like, the lesser experienced people?
Don't let people push you around.
Like, how do they get comfortable doing that? Because I feel like a lot of people aren't.
I mean, yeah, I wasn't either. None of us, I feel like, were, but I mean, look, at the end of the day, this can happen again to anyone. Like, anyone can be taken to court for a mistake, and they're not going to care if you just got off orientation.
Yeah, because
you're not going to care if you just got off orientation, it's your very first day on your own, or if you've been a nurse for like 12 years. You're going to get the same amount of scrutiny and like punishment.
That's facts. Actually, now that I thought you said that. Because they say that once you come off orientation, that you're safe to practice on your own. That's why when you get fresh off orientation and you're just thrown there, when you got the same amount of patients. I know some hospitals give you lesser amount of patients, but a lot of them just kind of give you the same amount as everybody else and expect you to do the same quality work, even though you just got on there. It's because they say that you're safe to practice as a nurse after orientation. So if you don't feel comfortable doing that and like you're a new grad or whatever, ask to have your orientation extended. Because like doing your orientation process, definitely like talk to your preceptor and be like, hey, like let me try to handle this all on my own, and use them as a resource when you're orienting, because you don't get that back like when you are on your own.
No, yeah. And like while you're on orientation, especially as a new grad, like as your preceptor, I'm taking responsibility for what you're doing. And like if you make a mistake, I'm the one that's going to get called in to my manager's office to talk about it. Like, not you, because I'm taking responsibility for you. But the day you come off of orientation, it's all you.
Yeah.
So I think new nurses just need to learn to advocate for themselves. So at the end of the day, they're going to get treated the same.
Yeah.
Like the whole excuse of I'm a new grad is not going to work.
Yeah, it's not an excuse. They don't care how long you've been a nurse. They're just like, well, you're a nurse and you learned this in school. That's what they told Redonda with the mixing of the meds. They were like, you learned that in school, that this med is just liquid and blah, 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 blah. Now, you know how many meds we learned in school? Yeah. Like, nobody remember that shit. But at the same time, like I said, since everything does fall back on the nurse, you have to think more on your side of things. Like, what do I have to do to prevent this from happening to me? So take y'all time, look through y'all orders at the beginning of y'all shift and actually read them, because I can't stand people who don't.
There was an order for that?
I didn't even know. Like, what? Girl, stop playing with me. You might not get that report. Don't trust anybody.
Don't trust anyone's report. Look at it yourself.
Yeah, don't trust anybody's report. Just smile. Okay, like, you write it down, make a note of it, and then if you see that it stands with the order that's actually there, cool. But yeah, you can't trust anybody in nursing, because like I said, everything falls back on you. So that excuse of, oh, the ongoing nurse or whatever.
They didn't tell me about this.
Yeah, they didn't tell me that they were trying to do that, or I didn't know that that was the plan. They don't care. You are the nurse. You assumed the responsibility of the patient when you came on that came on the floor and you took report on that patient. So it's on you to look at your own, the vitals, the meds, you know, all that stuff, the lab values, the orders, like that's all on you. And you can't use anybody else as an excuse. Obviously, as you can see, they don't give a fuck. Like,
it's every man for themselves out here.
No, literally, it is. And then if you do ask somebody for help on your patient, because if this wasn't her patient and she was doing this for somebody else, make sure you have a full understanding of like what's going on with that patient before you just medicate them. Because when you scan stuff, that's on your name. I always double check. I'd be like, what they ain't paying for? Like, what's going on?
And also, you need to like know who to ask for help and who not to. You got to know who you can rely on, because obviously in a perfect world, everyone would be like an amazing nurse or an amazing whatever, and everyone's competent and this and that, but like, you got to pick and choose who you need to ask for help with.
Yeah, who can you trust to do stuff efficiently and whatnot, and who's actually going to do it and not just say they did it and didn't actually do it. Like, it's a lot that goes into this. It's kind of crazy. Like, you should be able to trust your coworkers, but you can't.
Yeah.
Please see my video on prudent nursing. Everyone's not a prudent nurse. Everybody's not a competent nurse. Definitely scope out your coworkers to be like, okay, like this one ain't worth shit and this one is. It is just facts. I was telling Kelsey one time when we first started, I was like, I like the techs more than the nurses.
Our place?
Yeah, when we first started, I was like, I can't trust none of them. So then I'm like, okay, I can trust this one, this one, this one. If I need something, I know I can call her. It's just, you really have to do that everywhere you go. You have to be very observant. And because at the end of the day, like I said, all of this comes back on you, and you're really just trying to protect your livelihood. That girl's never going to be, I mean, now she's a felon. Hell.
Yeah, and her name is everywhere. So
yeah, like people know who she is. Like even people in the non-medical community know who she is.
It's just like, who knows what she can do.
That's crazy. Like that's how you have to think. Like, are you gonna risk your livelihood on somebody you don't even know, like, or care about necessarily? Yeah. It's just like, that's just crazy. Like, there's money to be made in nursing. Now you cut into my bag. We have a problem. And then now let's not even get into the stress of nursing school. Let's not even get into the stress of nursing school. Not me working my ass off to become a nurse and then I lose my license.
Yeah, not even like 5 years later.
Yeah. Oh, and then what were we saying before? That it's like 10 years is the amount of time, I think?
It's either 7 or 10 years. So like if an incident has happened with a patient, they have up to 7 to 10 years. I don't know which one it is, to pretty much bring it to court or bring it to light. If you've exceeded that, you kind of can't.
Yeah, something like that.
So like if in her instance, like obviously like right when all that happened, she knew in the back of her head she killed a patient because of her mistake. So like they had up to either that 7 or 10 years to bring it to court and have like something happen of it. If they pass that time, like it's like null. It's like you can't.
Yeah, and that's why I was saying to chart everything, because I mean it's never happened to me and hopefully it never will. But they always say like if something does happen, they just go based off of your charting, and you know how many patients we have like in that time span. Like you're not gonna remember most likely. So you charting like very thoroughly will help you remember, and it will plainly say like what you did and did not do and why you didn't do it. So that's why anytime I have a concern and the doctor don't do what I think they should do, per MD, patient blood pressure was this at this time, you know, whatever, or patient was feeling like this at this time, per MD, blah, 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 blah.
I let him know. He read my message, left me on red.
We'll continue to monitor.
I keep my fingers crossed.
Y'all have to make sure y'all do that, because it can come back and bite you at any point. Like we said, this happened in 2017. Like, that's crazy. It's been so many years since then. So, you know, just protect yourself. And if y'all are in a situation that is not safe for y'all, quit and work somewhere else. There's numerous opportunities for nurses to have, like, good jobs. So don't stay somewhere out of loyalty. Fuck that job. But for real, they don't care about you anyway. So the people might care, but the job, I mean, like, come on.
The company itself, no.
They don't even know who you are.
They'll hire another nurse in like 3 seconds.
They're trying to see if they will give you the PTO off to go to your kid's birthday. Like, come on. Like, it's just like, why I gotta fight for this? It's my kid. Like,
if you're thinking about calling in, just do it.
That part too. You know, do what's best for you. And I guess that could, we can say that too as a contributing factors, because I think a lot of errors, like medication errors, could be made because of short staffing and like you working long hours or you working overtime.
Being burnt out.
Yeah, if you need to call in, just go ahead and call in. Who actually cares? They're going to figure it out because they have to figure it out every day. Literally every day they have meetings about staffing and whatever. So if you feel like you're not up to par, because like I said, anything can happen on any day, you kind of have to think about like, am I safe to be a nurse today? Because sometimes you're not, and you just have to be honest with yourself. Even if like you're in a bad like headspace, or like you know like family issues, there's many a times I called in because me and Jordan had a fight. Not that many, maybe twice. But I've been like
you're not gonna be able to physically be there.
Like focus. Yeah, I'm not able to focus because I know I'm gonna be thinking about that the whole goddamn day.
Yeah.
Or it's just like, oh, we was fighting last night. Now my ass been up till 4 o'clock.
Yeah.
I can't settle, y'all. I can't settle. Like I have to finish the discussion. It is not finished until it's finished, and then I can like get peace. Like I can't sleep. I'll just stay awake. Ain't no way I'm about to be over here dealing with the bullshit of nursing.
Like 6:45 in the morning.
Yeah, absolutely not. So I'm like, like y'all have death in the families. Like y'all really just, you know, I'm just laughing because I just got reminded of a time. I wasn't a newer nurse, but this is still when I was kind of just like grinding. I had to charge in this other unit and I had gotten in a car accident on the way to work and I was still trying to go to work.
Hell no.
That's why I tell you all the time, I wish I was like you.
I'm like, hey,
no, literally.
Like, I'm not coming.
Literally, I called them. See, this is an example, y'all. See, this is what I'm telling y'all. They don't care about y'all. I called them, and I don't think she meant it this way because my managers were cool at that job, but I liked my managers a lot, and I liked my charging a lot. Like, the reasons why I left is because it was too far from my damn house, and I need to be on day shift. It wasn't because of the people.
Yeah.
But I called her and then I was like, hey, I just got in a car accident or whatever. And she was like, first she did ask, like, are you okay? Blah, blah, blah. And then the next question, are you able to come to work?
When you come in?
Yeah, are you able to come to work? And I don't think she meant it like, you know, like expecting me to. I think she was just trying to see what the situation was. Yeah. So I don't think she meant it like maliciously or anything like that. But I was just kind of like,
damn.
I was thinking, I was like, yeah, I can come in because I got like my tire blew out on the highway and I hit like the medium, but it was kind of crazy because I was like on the beltway, so I kind of like hit like a full like I feel like I was in Fast and Furious. I was in like the far right lane and I ended up facing like oncoming traffic on the far left lane, like it hit the median and then like my car was totaled. So I was thinking like, yeah, I could go in, like I'm not hurt, like I'm fine or whatever. And it was a police officer who told me like, nah, like, don't go. And I was just like, you think I shouldn't go? Like I was really trying to like rationalize, like, I should go to work. I'm
I'll deal with this car later.
Yeah, he was just like, no, I think you should probably take the night off. And I was just like, you sure? Like, so like, that's why I was telling them, I'm like, I wish I was like you when I was a younger nurse. Because I'd be like, I was really trying to figure out a way. I'm like, well, I can't, I'm fine. Like, I feel good.
I'm going to leave my car here and I'm going to Uber to work.
Yeah, no, literally. I think, like, we were discussing that. And I was just like, oh, you know, I'm like, the car is fucked up, but I'm okay. I can still go in. Like, and I'm charging. That's what I was thinking. I was like, I'm charging. I'm going to sit down.
Oh, really?
Yeah, so I was like, I'm going to be sitting down.
Being charged, though, and having to call out is a whole different level.
Yeah, I was charging, so I was really trying to think. And I was like, well, I'm going to be sitting. I'm not going to be doing a lot of manual stuff. So I was like, I should be okay, right? And he was just like, I think you just shouldn't go. And I was like, I guess. I think I called her back and I was like, hey, I'm not going to actually be able to make it. But it's just, you know, y'all, you really need to think about yourself first. Because who knows? I actually was okay. I think I wasn't like one of those sore situations. You know how sometimes you're sore after a car accident?
Yeah.
It wasn't like that for me. But if I had been and like if they needed me to do something, I would not have been able to do anything.
Yeah.
And I don't even know like how well I would have done like staying awake.
Or even just
because I work night shift. Yeah, because I work night shift. Like some stuff traumatizes you, you know?
Yeah.
So it's just like, you know, just better take the time out for yourself. So we're just telling y'all, you know, think about yourself first. That job is going to figure it out. They have no choice. So it's just like, whatever.
They're going to be short stuff regardless, so.
And I think I told somebody that recently too. I'm like, just call in if you really need to, because I'm like, it doesn't matter if you're there or not. They're still short.
Yeah.
And they're not going to make.
You're not going to get like a bonus for coming in. Like,
yeah, it's not like they're going to give you an easier assignment or anything.
Yeah.
It's going to be like, oh, well, you know, since you really didn't want to come in, let me take it easy on you this day. Just think of your worst day as a nurse. That's what I think of. Like, am I able to handle that today?
If not, I'm going to stay home.
Be like Nama, take a 2-week vacation.
At the same time? And never come back?
I'm just saying. You got any other thoughts that we should tell them before we go?
There's a lot of thoughts, but at the end of the day, just you come before anyone else. When it comes to your job. You know?
I think nurses are just not good at that in general. Because I feel like that's us as humans. Like, that's why we're nurses. It's because we're like givers and like we care.
So the healthcare will eat you up. So then you kind of have to have like that backbone.
Yeah, you have to think about that. Like, because I think I was talking to someone else before. I always wonder how them 20-year-old nurses do it. I'd be like, how the hell are you still here?
Oh, like who've been nurses that long?
Yeah, who still work at the bedside? I don't understand. I'm like, I get it now. You see some of the good ones, they do their shit, they keep to themselves, and they're just like, I'm not doing that. Or, you know, you have to really think about your longevity. If you don't know, like, what you're going to do after bedside nursing, kind of have to think, like, how can I have to start
planning that kind of, like, now, right? Like, like, earlier on, you can't one day decide, like, now what I'm going to do next. Or it's like, you kind of have to plan.
Yeah.
But also, I feel like healthcare was so much more different.
It was. I was literally orienting with a nurse yesterday. She's been a nurse for like, and more than 10 years, I know for sure. She's like almost 50, she told me. And she had been doing it since like, I guess she graduated pretty much. She was like, we used to have so much fun in nursing. Like, I used to come to work and I'd have fun and blah, blah, blah. She was like, it's just not like that anymore.
Yeah.
And I was like, damn. Missed it. I'm like, I had fun in my old, it's too much politics now and everything's about money.
Yeah.
And I guess that's where some of the problem comes in, because it's like, what I want to do at work is I literally just want to take care of my patients. I don't want to have any of that other shit.
I don't want to kiss ass for
it's just not.
HCAP scores.
Yeah, and honestly, it's kind of, what's it called? I guess just a balance though, because it's just kind of like, can you have high patient satisfaction scores if your nurse satisfaction is not good?
No, you can't.
So it's just like, shouldn't we focus on us? Yeah, because I'm like, you're worried about retention, right? You need to keep people.
And how are you going to keep people?
Right, you need to make them happy. If we're happy, then we'll make the patients happy. And it just comes full circle, but I don't know why they never start with us.
Yeah.
We're the ones in the room with them all the time. They could feel the energy. They know when we short.
Look at Miss CNO over here.
I'm just saying, I don't want to go back to school, y'all. But I just be thinking like
look, I got some good ideas.
It's kind of obvious. It makes sense. It makes a lot of sense. Make us happy. Everybody else will be happy. Yeah. It's kind of like the wife in the household.
Happy wife, happy life. Same thing with your nurses. Happy nurses. I don't even know. Better patient satisfaction, better HCAP.
Everybody happy. If we happy. But I guess that concludes today's episode, you guys. Let us know what y'all think about what we said in the comments. If y'all have any fresh facts on Redonda that we missed, let us know, because we looked through a lot of articles, like I said in the beginning, and some of them were very conflicting. So if there was any new information that we didn't mention, or if there's anything that y'all like to comment on, definitely let us know down below. Like our video. Let us know how we fix this shit. Like, how do we get this together? Because I don't want to quit being a nurse. I like my money. I like my flexibility.
Yeah.
I was asking people, like, what are you going to do if you don't do bedside? Like, I like being a nurse. I actually do. And because people were worried that nurses want to quit, and I'm like, I wouldn't quit nursing because everything else is kind of bullshit too, honestly, in their own on their own way.
It's perfect.
Yeah, and I'm kind of like, we can pick up whenever you want to do. We could work however you want to do for the most part, especially me now since I'm fuck pool. So it's just like, nah, I don't really want to leave, but I'm like, definitely the system is not what it needs to be, and we need to figure it out. So y'all let us know what we need to do. We need to get it together. We need to combine. I think a lot of nurses like realized in the pandemic, our worth.
Oh yeah.
So we need to get it together, guys. So y'all let us know what y'all think. Drop an emoji for Nama. She'll be back, I'm sure. And we'll see you guys later. Bye.
Bye.